The pediatric grand round on this very lovely summer day that I'm wishing for. Our speaker today is Dr. Jeri Lantz. Dr. Lantz is an associate professor of internal medicine and pediatrics at VTC SOM and VCOM. She has served as the division chief of general internal medicine since 2008 and the division chief of adolescent medicine since 2010. She's a graduate of the University of Iowa College of Medicine and did her internal medicine and pediatric residency at Wayne State University in Detroit, Michigan. She has been with Carilion Clinic since 2001. She is active nationally and regionally in the American College of Physicians, American Academy of Pediatrics, Society of General Internal Medicine, and Society for Adolescent Health and Medicine. Please join me in welcoming Dr. Jeri Lantz.
Okay, I don't have any disclosures, no big pharma interests, for sure, no big food interests. All right, here's my objectives. We're going to review the problem of elevated blood pressure and elevated lipids in the pediatric population, what it might mean for them in adulthood, go through some definitions so that you can easily spot hypertension and high lipids in our young people. I'm going to try to answer the question of what additional workup is needed and empower you to outline some strategies and how to treat and when to treat, and then we're going to whip through some cases. Okay, these are things I'm not going to talk about in the interest of time. I'm not going to talk about inpatient management of hypertensive emergencies. I'm going to leave that to my PICU friends. There's all kinds of great protocols for that, so I know you guys will be able to handle that just fine. I'm not going to spend a lot of time talking about the less common congenital or genetic syndromes that are associated with hypertension, but I will throw in a few pearls for those third years that are studying for boards of odd things that come up in the foils. Sorry, Joe, I'm not going to talk about tonsillar hypertrophy or obstructive sleep apnea as it relates to hypertension in particular. I am absolutely not going to talk about politics in any way, shape, or form. And I am not going to talk about college football, so don't ask me how I feel about the University of Iowa and the Minnesota game from a couple weeks ago that I'm still not going to talk about. So here's the question, does elevated blood pressure or lipids in the pediatric or adolescent patients, does it even matter? Does it matter? Like, do they feel it? Is anything, happening right now? And I'm just gonna suggest to you that it matters. I wanna introduce you to a patient of mine that I'm gonna call LC. This is not his picture, but it's a little bit like what he looked like not too many years ago. He's a 35-year-old now. He's a patient of mine. Unfortunately, he's got end-stage renal disease. He's been on dialysis since he was 30. And he had his first coronary event with an MI at age 32. So here's LC's backstory. So he was always described as a big guy. He was a premature baby at 32 weeks. He had a short NICU stay. He doesn't know, but his mom couldn't remember either if he ever had a renal or a umbilical artery catheter. But he did have a short NICU stay, so he started off kind of small and turned into a big guy. There is family history of hypertension in both his parents, diabetes in his mom. He remembers that when he was a teenager, somebody told him during a sports physical that his blood pressure was up a little bit. And then he remembers having a lipid panel done sometime maybe when he was a senior or freshman in college, and somebody told him that maybe his cholesterol needed a little work. But he never really got started on any meds until he was 25. All right, then I want to introduce you to Suzanne. So Suzanne's a 36-year-old patient of mine who I met a couple of years ago. I met her after several pregnancies, and she had preeclampsia in 3 of her 4 pregnancies, kind of slipped through the first pregnancy just fine, didn't have an issue, but the others turned out to be a little bit tricky with an emergent C-section with her last pregnancy because of elevated blood pressure. She remembers that when she was a senior in high school, somebody said, hey, your blood pressure's up a little bit, and probably should get some exercise, maybe cut out some junk food, and which she sort of thinks that she sort of did. And then she kind of dropped out of healthcare as most 17, 18-year-olds do, and didn't appear anywhere until she was pregnant and showed up at her obstetrician at age 26. So now Suzanne is on chronic blood pressure meds, and she's now got hyperlipidemia. And she's not a big gal. Her BMI is about 26. All right, so I just want to show you why this matters. So this is from the Hypertension Journal. It's an older article in 2015, but the x-axis is age, the y-axis is systolic blood pressure, and I just want to impress upon you that hypertension, unfortunately, does not just go away. So starting at age 7, that top line, that brown line, is would be the definition currently of stage 2 hypertension. So look at how it just stays, and it just gets worse. So when we pick it up early, it's likely that those kids actually could be hypertensive through life. The green line below it would be stage 1 hypertension, and then this brown line, second from the bottom, is the elevated blood pressure, or the pre-hypertensive category that we don't really even call anymore. And then the bottom is normal blood pressure. So I just want to suggest to you that by mid-30s, if you have hypertension as a young person, you probably will still have hypertension. So that's why it actually is important that we pick it up. This graph shows how this might relate to cardiovascular events. So this is from the Cardia study. And just what I want to impress you with this graph is this is stage 2 hypertension. The y-axis here is incidence of cardiovascular events. And so what happens if you are hypertensive for more than 10 years? Your risk basically goes up tenfold of having cardiovascular events that happen. And so stage 1 is this blue line, and the normal blood pressure is this bottom one down here. So it's the length of time that endothelial lining is under high pressure, whether, cause effect, that actually gets people into trouble down the road and leads to disruptions that lets plaque kind of deposit and then causes folks to have more cardiovascular events in the adult world. All right, here's the definition. So in 2017, the AAP got together a big guidelines committee, and there's a huge document on hypertensive guidelines. It's actually a really good paper. It's just about 40 pages long, but it's got some good stuff in it, so I've cut out some highlights for you guys. There has been some advancement since then, but a lot of this stuff is really still the same. So the chart I have here on the left is blood pressure values requiring further evaluation. And I just want to point out to you that, kind of by age 7, your diastolic should really be still under about 70, okay? By age 13, universally, if you've got a diastolic pressure of 80 or higher, that probably needs to be at least, a double check in your head. If it's 90, that's bad. That's already stage 2 at any age, okay? So that's bad. But, there are great, well, when I was a resident, we called it Aunt Harriet's handbook. But when you, so Harriet Lane is an example of, there's great handbook, or, tables in there that also relate to patient height and size. And so, if you've got a young patient on the, extreme of one size or the other, you might want to take a look to see in terms of height and what a normal blood pressure is. But that's the general rule of thumb. I kind of look at the diastolic first, because that kind of tells me where the pressure is in the resting heart. Then look at the systolic. And what you base it on is whichever of those is the closest to the normal range. Go with that one when you on your first pass look. All right, if they're less than 6 years of age, please think about underlying conditions. So most of those folks will have renal disease, maybe have had a history of umbilical artery catheterization in the NICU. Maybe they've got neurofibromatosis. Maybe they've got congenital heart disease that hasn't quite been picked up yet. For those of you who might be studying for board soon, think about Little syndrome is something that comes up sometimes in a foil. So that's autosomal dominant. They have hypertension and they have hypokalemia. And then there's adrenal disorders and Cushing, and the list is actually much longer than this, but these are some of the big ones. So in the office, you got somebody whose blood pressure is a little bit on the high side. So then you have to decide, is this somebody who has a hypertensive kind of crisis situation? And chances are, probably not. But when you look at so that means there's symptoms or evidence of end organ damage, and urgency and emergency are similar, except for emergency means that they have some end organ strain going on. So
if you look at the symptoms of urgency, it looks like 80% of our pediatric patients that I've seen in the last couple of weeks, irritability, poor feeding, headache, nausea, vomiting, fatigue, dizziness. But if you've ruled everything else out and the only other thing you've got is, high blood pressure, think about it. It might be, more of a hypertensive urgency kind of situation. And then the emergency situations are the folks that we're going to introduce to our colleagues in the PICU, because they're going to need that's going to be the folks that have consciousness alterations, or maybe some congestive heart failure sort of symptomatology, or hematuria. So those are folks that are going to need a little bit more intensive intervention, obviously. Press syndrome, those kind of things. Okay, so assuming your child in your office does not have any of those things, then you're going to take a look and say, I wonder if I should recheck this blood pressure. And the answer is yes. Please recheck the blood pressure. So and typically we would want you to recheck the blood pressure manually. Our nurses do a fantastic job of taking blood pressures, but we do have manual cuffs, and so that's the first step is check it yourself, make sure the right size cuff was used. So in our automatic blood pressure measuring devices and some of our manual cuffs, they label them for us, right? There's this little tiny person to a moderately tiny person to a medium-sized person going all the way up to like an extra large person. Okay, they've got these little pictures on them so you can look at that. But you should probably double check to make sure that the cuff meets these requirements as well. The bladder should cover 80% of the arm circumference, and you measure from the acromion to the olecranon. And the width of the cuff should be about 40%, so a little under half of that arm length. So that's the right size cuff. Remember, if you use too small a cuff, your blood pressure is going to look higher than it is. If you use too big a cuff, it's going to look lower. Here's some gizmos that are getting better and better all the time. So in the not too distant future, we're going to have some great technology for less invasive blood pressure measurements that will even work for children. They're working on these now, and there's some good ones that are coming out. The adult ones are getting better and better. And so, there's watches that have blood pressure measurements. And so we'll probably be seeing a slew of more wearable kind of devices that will at least give us a hint. This little picture underneath our patient here is a 24-hour blood pressure measuring device. We use them in the adult world. Soon, hopefully, we'll have one, at least in the adolescent clinic, that we can send people home with. So if you're worried about white coat hypertension, or if they're just scared on a given day, perhaps that will be a good option that we'll be able to use in our pediatric patients coming soon, because they're getting smaller and smaller and less troublesome. And then you can really take a look. And if it is that patient that has hypertension more at night, maybe they need to see Dr. Tamez, because maybe they've got sleep apnea kind of stuff. So, that actually can give you a good, some good pieces of information about how their pressure is over the long haul. Okay, this is a very wordy slide, but this is the best pressure measurement best practices. So I just want to point out a few things that I find kind of entertaining when you really look at this list when it comes to pediatric patients. Okay, number one, the child should be seated in a quiet room for 3 to 5 minutes before measurement, with the back supported and the feet uncrossed on the floor. So I can't think of the last 3-year-old that I could say actually met this criteria. Perhaps you guys might have different 3-year-olds than me, but I find this hard. It should be measured in the right arm for consistency, with comparison to standard tables. So the reason for the right arm is that's for right arm dominance. So you typically want to get the blood pressure in the dominant arm is usually the highest reading that you're going to get. And the arm is supposed to be uncovered above the cuff. And the patient and the observer should not speak while the blood pressure measurement is being taken. Yeah. So again, I don't know, I think that's hard in our pediatric patients, to get a good blood pressure. But keep that in mind, is that a lot of times we may have false readings, based on the fact of how our pressure was taken. And then I'm sure I probably should have learned this in residency. I'm sure that our pediatric cardiologists know this, but When we take a leg blood pressure, we're really supposed to have those kids on their bellies. They're supposed to be prone, and we're supposed to be listening over the popliteal artery. So just kind of keep that in mind. And for the students and the residents, remember that your blood pressure in your legs really should be higher than your arms. And so if it's not, if it's lower, you got to think about core, because that's one of the things that we're really looking for. Okay, so there are a few times in kids less than 3 that you really should check a blood pressure, and that's if they have a history of being premature less than 32 weeks. Obviously congenital heart disease, if they have recurrent UTIs, the kid that you've sent for the VCUG and the further workup there, probably you might want to think about checking a blood pressure and a well check. If they've had a transplant or malignancy, there are other systemic illnesses that might have hypertension. Think about those folks actually getting a blood pressure when they're even younger than 3. And then remember, we give them things and they take things that also cause high blood pressure. So our patients who are getting ADHD treatment, folks who are taking decongestants and stuff like that, their blood pressure goes up. Contraception, steroids, tricyclic antidepressants. And then there's things that we don't give them, but they take anyway, like, somebody else's amphetamine, or, somebody else's illicit substance. Okay, and please remember in our teenagers, they're doing stuff, okay? And so they are, self-medicating before they go to school, they're self-medicating on the weekends, and so sometimes they're self-medicating with these crazy energy drinks. And I think it's fascinating to look at like the labels to see how much caffeine and stuff is in these things, but they're crazy. So I always, if it's a teenager, I always ask them what they might have ingested in the morning before, coming to school or coming to the clinic, because sometimes you find out all kinds of stuff. And we're raising all kinds of like mini pharmacists. So in their vape pens, not only are they, getting whatever the manufacturer put in, sometimes they're opening them up and they're adding stuff in. And so you have to kind of, if you get a vaping history, you need to find out if they're actually adding things to their vape or if they're, and what kind of thing they're vaping, because it can be very different with what's in there. And then we're also in a generation of young people that feels like sometimes they need like a double espresso or, one of these fancy drinks before they come to the office. And so sometimes they have, over-caffeinated just coming in the door. So I want to introduce you to 13-year-old Marcy. So she came in for a well check. She's a little nervous about her HPV vaccine because she thinks that you might have tried to kill her last year when she got the first one. And she does need a physical because she's changing schools. She hasn't been sick lately. The family says there's no past medical history with her. She was full term, really no significant family history. Parents are both healthy. Her exam's normal, but her blood pressure is 120/82. Even on your recheck, that's kind of what it is. Her BMI is about the 60th percentile, so what do you do? All right, so here's your choices. And ignore the blood pressure. We'll just check it again next year. She's 13. We got she's got years before this will be a problem. I'd ask again for a blood pressure recheck. I'm just going to go ahead and start her on a calcium channel blocker, because she's bound to be, severely hypertensive. I'm going to order some labs. I'm going to ask maybe for some home or some ambulatory blood pressure measurements. I want to remind you that the school nurses are out there. They all have blood pressure cuffs. They're incredibly helpful, and they will be so happy to help you check some school blood pressures. So sometimes just writing a note, can be to the school nurse, and they'll check them. Maybe you want to do both. Maybe you want to get another blood pressure recheck in the office. And maybe you want to ask for some home or ambulatory blood pressure measurements. Maybe you want to do absolutely everything. I'm just going to do everything today. Maybe you want to do none of it. You want to say, Lance, go home. This topic is boring me. I want to do none of this. I don't want to think about hypertension. Okay, so I would encourage you to please do B&E. At least recheck it and get some more measurements, and don't ignore it and think that this is just maybe going to go away. Hopefully it will. Maybe that's an erroneous, value, but, if it doesn't, you can really make a difference. So that's what you do. And our blood pressure at home, in school, and on recheck still remains high. It's still over 130 systolic and over 80. So unfortunately, yes, it looks a little bit like hypertension going on. So then you have to think about, is this primary hypertension or is it secondary? Is it something that her body's just doing, or is some other thing about her? is caused her to be hypertensive. If she's over 6 and it has a high BMI or a strong family history of hypertension or premature coronary disease, I'm going to encourage you to think about checking a uric acid. There's some tremendously fun literature going on with uric acid and how it's a marker of disrupted endothelial lining. And it tends to correlate very well with primary hypertension in our young patients. So we don't think about checking uric acids because we think about that with like tumor lysis syndrome and stuff like that. And in my adult patients, I think about it if they come in with a big old red hot knee and they have gout attack, right? So otherwise we haven't really, uric acid kind of goes, unnoticed. And a level greater than 5, which is technically in our lab's normal range, is not necessarily normal in our pediatric patients, and it tends to correlate with primary hypertension pretty nicely. And so if they have some other reasons to think that this is a primary or essential hypertension, and their uric acid is a little bit elevated, you're probably right on the money. It's probably primary hypertension. Doesn't mean you may not do some of that secondary workup stuff, but you can probably in your head head down that road. All right, so what you're going to do first is lifestyle modifications. So the biggest dietary advice that you can, tell your patient and your family is you gotta get rid of the soda, you gotta get rid of the juice, because fructose matters and high fructose corn syrup matters a lot, because now we know it also probably is adding to all of our fatty liver kind of issues. But it's disruptive to that endothelial lining, which will set them up for issues later. Think about limiting their breads and grains. They're loaded with added sugars. Cut out the inflammatory oils, so seed oils, the canola, the vegetable oil, all those things can be inflammatory. And then cut out ultra-processed foods. What did I hear? $66 billion a year in U.S. kids is the expenditure for soda consumption. Isn't that creepy? It's awful. And it's on, with your, food stamps and SNAP program, you can get all the soda you want. It's covered, so just say it. But again, I'm not talking politics. And then, you have to tell these kids, you're not, no tobacco for you, not now, not ever, this is one of those things, your blood pressure tends to run on the high side, this would be a really bad reason, because they don't feel bad. So you got to help them understand that, here's some choices, that are going to keep you healthy over the long haul. And really don't think about vaping. When your friends are vaping in the bathroom at school, don't join them, because, you don't know what's in that, might make your blood pressure go up, bad things can happen either now or down the road, and then they need to watch their caffeine. So, the food label, on the far left is not food. That is a ultra-processed item. In the middle, it's like carrots, snap peas, cauliflower, okay? And then the one way on the right is organic pre-cooked green zucchini and organic pre-cooked yellow squash. So unfortunately, I worked for the FDA when that other part of the label came out. And I would encourage you to tell your patients to kind of ignore that other part of the label and go right for the small print, go right for the ingredient list, because the other label can be kind of misleading in terms of sugars and things like that. But if we really get young people and their parents looking at the ingredient list, and if a general rule of thumb, if you can't pronounce the stuff that's on that ingredient list, it probably shouldn't go in you. But you get one militant teenager reading ingredient lists in the house, they'll change the whole family. So if because they will think that, their parents are trying to poison them with, what they picked up from the grocery store. So here's the thing, those are the things you said goodbye to. Now you're going to add in vegetables, not just the potato. The most common vegetable consumed by our kids in the United States is the white potato in the form of a French fry, sadly. The most common fruit consumed by US kids is the tomato in the form of ketchup. Okay, so you have to sometimes tell them what a vegetable is because they may not have had much experience with that. Sleep matters. So this is another great thing you can tell the whole family. Everybody's got to get some sleep because Sleep is the time that you kind of do repair. And so they got to get their circadian rhythm back in check. And that'll actually help some people's hypertension, dramatically. Exercise, even if it's 20 minutes, try to institute like taking a family walk, 20 minutes, go out and, usually you say, walk at a pace that you can't sing Mary Had a Little Lamb comfortably. And that's kind of a fun family thing to do, to see who's panting with Mary Had a Little Lamb, then you know that you're walking fast enough. But it's little interventions like that can make a huge difference. Remember, most of our kids in the Roanoke Valley are super low on vitamin D. Everybody I check is like got a level of 9. So think about making sure that they're getting some sun or not getting some vitamin D, because they're all under fluorescent lights. And if it's a young person that's already been on metformin or some of our other meds that cause B12 deficiency, have been on PPIs and things like that, think about if they need to have a little extra. Here's a cool one, family meals, at least 4 times a week, probably make the biggest difference of anything, because automatically, this is great advice for the parents too, because they need to be checking in with these kids to find out how their school day was. But if they can schedule a family meal at least 4 nights out of the week, doesn't have to be every night, where everybody sits down and there's not electronics, most kids will eat on average 2 to 3 more helpings of fruits and vegetables a day with that intervention alone. It gets people cooking, it gets people less, even if they are doing DoorDash or something, maybe they at least think about what's going in their mouth and what is going to be sitting at the table with them. And remember, most of our pediatric patients are being raised by the Fruit Loop generation, okay? This is not, they were raised having Fruit Loops and Captain Crunch, and they may not know how to cook, okay? So every bit of information that you're giving this kid and this family, you're also talking probably to a parent with 1 or 2 chronic diseases, because 60% of adults between 30 and 60 have 1 to 2 chronic illnesses. So you're doing the whole family a favor if you can just help to change that trajectory. I know that Dr. Powell sees that in the Healthy Lifestyles Clinic all the time, but as you're talking to the kid, remember that you're also talking to the grocery buyers. Okay, so back to primary versus secondary hypertension. So most are going to be essential or primary hypertension. Think about that uric acid level. It's cheap. It's kind of can tell you a lot. But then bring them back for a recheck. You can do this yourself. You do not need to refer them. So just bring them back. Talk lifestyle, talk the lifestyle modification, educate the family, and then you got to think about, could this possibly be secondary hypertension, which by and large is the most common cause of secondary hypertension is in a young person is going to be coming from renal parenchymal or fibromuscular dysplasia of the renal arteries. Okay, consider some labs. I'll go through a list here in a moment, but it's easy. This is easy stuff. I used to say, this is not rocket science, until my husband became a rocket scientist, and now I can no longer use that line. So, but it is still not rocket science. You can consider renal vascular imaging. We've got great little duplex studies that will tell you how the renal vasculature holds up and the symmetry. Bring them back for that appointment just to recheck blood pressure. And then if you didn't on the first pass, take a look for things like coarct and double check to make sure that your pulses are symmetrical and that you're not missing something. Okay, so going back to Marcy, she probably had stage 1 hypertension, but what if she came back and she had these kind of blood pressure measurements, 155 over 90, or 152 over 90, 155 over 95? Oh my gosh, now this kid actually has stage 2 hypertension. Okay, so in the office, you got him in the office, so don't wait, just go ahead, get some labs, repeat the blood pressure, send the UA, check your upper and lower extremity blood pressures and your pulses, reiterate the lifestyle changes, and you got to tell these kids why this is important, because again, they don't feel bad, they're feeling nothing, so it's just another thing. But kids are actually pretty interested in how they're going to live their life and what kind of things are going to be important for them for good health. So really try to speak to the kid about why this is important to do, and why mom's not going to be, buying all of the Mountain Dew and the Coke, otherwise it seems like a punishment. But no, this is actually, our whole family's going to get healthier. And then you might want to, so depending on your comfort level, if they're going to come back, you may want to consider meds or recheck them at least. At the very minimum, you've got to bring that kid back to kind of see what's going on. So it's not something that you can just send them out. Stage 2 hypertension, send them out. Like, you got to think about meds at that point. Labs are easy. So think about a CMP. A CMP is going to give you a ton of information. It's going to tell you about electrolytes to kind of give you a hint if there's other adrenal stuff. It's going to give you a glucose. It's going to give you liver enzymes to see if they already have evidence of some fatty liver. In the right patients, think about if you need to get a TSH, think about a hemoglobin A1C. I never do drug screens as an outpatient, but if you've got an inpatient who's got something tricky going on, think about a drug screen there. And think about a rheumatologic workup. And then imaging, if they're less than 6, go ahead and just get the renal ultrasound, because you want to make sure that their kidneys look okay. And then think about end organ evaluation, especially like LVH. Our EKGs for hypertension and LVH in the pediatric population are not quite as sensitive as they are for adults. So echo's probably indicated if you're worried about that. And you can think about carotid intimal thickness measurement, which is, I'll show you in a second, which is also another way to kind of look at that endothelial lining. This is not going to be probably for those younger patients, but just things to think about. Consider if they need to have an eye exam. Somebody needs to look at their retina, which is, that great place that you can actually see a nerve and a blood vessel up close and see what's happening. And then OSA is also something that, by history, we're already asking them about snoring and things like that, in our well visits. So there's now great data on our pediatric population and carotid intimal thickness measurements, and so there's charts. So it's a little tricky in a wiggly patient, but if it's somebody who will kind of lay still and you have the right tech, these can be also nice measures of what's happening with the endothelial lining up close and personal. Okay, so in case you didn't believe anything I said, there's this table that's in the guidelines that tells you everything else, to think about getting for secondary hypertension. But it's easy. So you guys, this is definitely in the wheelhouse of the general peds realm. We can do all this stuff, and then we can save our extra tricky patients, for referral to our cardiology friends and our nephrology friends if we need them. But we want to save those referrals from our specialty. Okay, so you guys can do all this stuff. So again, stage 2 is when you consider meds, after assuming you've talked about all the lifestyle modifications. And the meds are easy. Okay, so ACEs and ARBs have been approved for pediatric patients for many years, and you can, if you're worried about it and you're squeamish, start low and bring it back and titrate up. Okay, it's not hard. Hydrochlorothiazide can be safe in our pediatric patients, and calcium channel blockers would be the other class of meds that are an easy thing to start that have fairly minimal side effects. Be careful with hydrochlorothiazide in an active teenagery person or somebody who's doing a lot of sports, because they'll get a little bit dehydrated on you, and so you have to make sure that they're hydrating well. And you notice I didn't really say much about salt. In the past we always said the DASH diet. Put them on the DASH diet, which is low sodium and everything. But if you cut out the ultra-processed foods, they are going to cut out their salt. So most kids actually can have some salt, because if you got them actually following a diet that makes sense and not just, Doritos and M&Ms, they probably are not going to get as much sodium as, as you think. And then remember, if you have someone who might be pregnant, either planned or unplanned, start with a calcium channel blocker and not an ACE or an ARB, because we don't need to create more patients. All right, so now I want you to meet Kevin. So Kevin is another patient of mine. I met him in his mid-20s after he came in with a bout of pancreatitis. He already had type 2 diabetes and hypertension that was diagnosed at a previous hospitalization. His BMI was about 30, he was 6'2" tall. He had no regular primary care. Just in the last hospitalization, he's gotten started on metformin and lisinopril. But when he came in to see me and we checked his lipids, or when he was in the hospital with me in pancreatitis, his triglycerides were over 900. His LDL was 120, his total cholesterol was 234, his HDL was 19, which is always a bad sign. So in our pediatric patients and in our adult patients, pediatric especially, man, you should see an HDL that's over 40, okay? So if it's not over 40, this is already a problem, all right? So just keep that in mind. So he had a very strong family history of coronary artery disease in his father and his paternal grandfather. His mom was a diabetic. All right, so we're going to switch gears and just talk briefly about hyperlipidemia in children and adolescents. So this chart kind of has the worrisome findings. So when you get your little lipid profile in the office, here's the things to zero in. If they have an LDL, a total cholesterol over 200, take a look at that, but then look at the LDL. And if the LDL is over 130, that's problematic, okay? That's high. Now remember, a lipid profile is a snapshot in time. It's what's going through the blood at the moment that you do the lipid profile. So it doesn't tell you about how much has been there for any length of time. Triglycerides generally in kids, 0 to 9, if you're doing a lipid on them, should not be over 100, and it shouldn't be over 130, if they're over 10. Okay, and triglycerides are very closely related to sugar intake. So also take a look, if this is the kid that is, drinking the, bottle of juice in the office and then you're checking the lipid, perhaps you, falsely elevated the triglycerides. So, but those should be kind of your cutoff numbers to kind of think about. And again, HDLs should really always be over 40 in this population. So the big thing that you can do as folks who take care of young people is really spot those heterozygous and homozygous familial hyperlipidemia patients who are going to need aggressive control of that LDL to keep them from having early coronary disease. And I'll show you those levels here in a moment. But those, and then the hypertriglyceridemia familial variants, those are the ones we really need to try to manage aggressively. As I was reading stuff for this talk, I was talking to some of the adult cardiologists, and I said, I love your tower, but I want the pediatricians to make it such that absolutely none of our patients need your tower. I don't want to put you completely out of business. Don't worry, we'll still have plenty of business, but I would love if we could just at least decrease the cardiac events in this community. All right, so this is not also very hard. This is easy stuff. So the way to kind of quickly look for familial hyperlipidemia is take a look at the LDL-C. And if it's greater than 160, that's probably a problem, and probably is a problem in a heterozygous kind of fashion, especially if they have other family history. 190, also kind of, with a family history, also worrisome. You don't have to send them to see, Dr. Doherty in genetics necessarily. You just need to kind of spot those numbers and go, that looks like trouble. And then homozygous, they'll have huge numbers. In fact, usually it'll be unmeasurable, but it'll be over 400 or over 560 of LDL. So those are the folks that we really can make a huge difference for if we catch that early and we pay attention. So again, lipid-lowering medications have been used in pediatric patients for a long time. So if you have somebody who particularly fits those categories of having either heterozygous or homozygous familial lipid disorder, statins actually have been used in kids, down to 6, and they block the cholesterol production in the liver. There's, the other ones for pediatric patients that are certainly usable is bile acid sequestrants, and then I can never say this generic name, Estimebe, which is brand name Zetia. Again, I have no pharmacological interest, but I never say that word on purpose because I can never say it. So they all work a little bit differently. Omega-3 fatty acids or fish oil is something, that has been used in pediatric patients, and then niacin also, but you can't use niacin and a statin at the same time. That's bad news. But they've been used, so don't panic about that. These are some things that we see in adults. You can use a little bit more fibrates, which, for hypertriglyceridemia. And the newest agent that you'll see some adult folks may be making reference to is the PCSK9 inhibitors. Those are injectable monoclonal antibodies for more severe cases. Okay, so in our adult patients, not so much in the peds patients, but I just want you to know about this because some families might ask you about this. Sometimes we do things like apolipoprotein analysis. And so every grand rounds is not complete if it doesn't have like some molecular image. So here's your molecular image. This is a little LDL that is floating around. And the ApoB is that kind of funky lining on the top. So if you're in a situation where the triglycerides aren't measurable because, or where the triglycerides are so high, that the LDL is not measurable, sometimes it's helpful to get an ApoB because it can actually help you quantify how much LDL is actually in there. So where cholesterol is not bad, we all need cholesterol, it makes hormones, we need it. It's just where it's getting deposited is the problem. And that ApoB layer is is kind of like the key that unlocks the door to deposition of that LDL particle, so that it can be dispersed to cells that need it for energy. Okay, you're not going to do coronary artery calcium scores on pediatric patients, but what I want to point out to you is this. So this is a test that we're doing more and more on adult patients to see when they have developed hard plaque or calcification of the plaques that are in their coronary arteries. Easy test, they just go in and get a little CT scan. It's kind of like a mammogram for the heart. But take a look at this blue line. These are the folks that I would love for you, wonderful pediatric partners of mine, to help us not have happen in the Roanoke Valley. This blue line is the early converters. This doesn't measure any, won't tell us about soft plaque in the arteries, but this will tell us when people have had plaque long enough that it's gotten calcium deposits. And so the folks who are in the 35 range, who are early converters, are the people who've been walking around with elevated lipids and hypertension long enough that some of those atherosclerotic plaques have now gotten calcified. So those are the ones who are more likely to have coronary events earlier in life. Okay, so back to Kevin. So despite intensive medical intervention over the next decade, Kevin developed chronic pancreatitis. He ended up having a leg amputation due to peripheral vascular disease. He had 2 MIs before his 33rd birthday. He unfortunately developed fatty liver disease, and he just died of liver cancer in the last year before age 40. It was very sad because Kevin had just gotten married, adopted his wife's 3 young children, and so here he was a dad with stuff to live for and things to do, and kind of heartbreaking that he kind of slipped through the cracks for as many years as he did. Remember, on the horizon, we're going to have less invasive monitors for better home detection of blood pressure. We're going to have better interventions with pharmacotherapy and certainly with testing. We're going to have a better educated public, hopefully, for nutritional strategies. And this little girl reminds me of my niece, Alexa, who when she was a little girl used to say, please, oh please, oh please, oh please, Aunt Jeri, all the time. So hopefully all of that will come about. So what's happening with LC? Well, he just met the love of his life. He's hoping to get started on a family. You might see him in clinic. You won't necessarily know him. He's still a big guy, but he'll hopefully be bringing in a baby sometime. He's on the renal transplant list, but he's had a rough go of it for a guy in his 30s. Suzanne, her blood pressure is currently controlled. She's a major exerciser, is a personal trainer, and she is like a warrior in the school system trying to make sure that we actually have fruits other than tomato in the form of ketchup and vegetables other than the white potato in the form of the fry. Marcy, she's a local basketball player in high school. She's doing great. Her blood pressure is currently controlled. She is on amlodipine. Okay, so Nelson Mandela says, we can change the world and make it a better place. It's in your hands to make a difference. So I hope that you will make a difference in the hypertension and hyperlipidemia of our young people. This is easy. You can do it. At least do all the workup stuff. And you can start the treatment. It's within your wheelhouse. All right. So a few mock questions. You have a 14-year-old rise at clinic with a toothache. Blood pressure is 160/86. And then when you, and 155/87 on a second check, 30 minutes later. Other than the tooth pain, he has no other symptoms. So true or false? You should be assessed for hypertension.
True.
True. Thank you. Begin the first thing you gotta do is just talk about it. You gotta, talk about it, point it out. Of note, on our EPIC parameters, Dr. Lockyer and I were just talking about this. Sometimes the blood pressure comes up red when it shouldn't. Sometimes it doesn't come up red at all. So hopefully with the next EPIC Horizon upgrade, that will change. But please, don't rely. If it's red, probably definitely take a double check. But even if it's not coming up red on the blood pressure, take a look and see if it actually matches up with where that child's age should be. And at a minimum, if it's up, don't ignore it. Bring them back in 2 to 4 weeks and then consider labs and imaging. Okay, your 10-year-old patient with a BMI greater than 99% has a lipid screen. She has an LDL of 160, a triglyceride of greater than 300. So you should counsel on lifestyle changes, which are the same lifestyle changes for the hypertension lifestyle changes, by the way. Consider referral to the healthy lifestyle clinic. Have them, let it be Dr. Powell's problem. Tell him to exercise. Bring them in for repeat labs and a weight check in a few months, or all of the above. Right. So just do it all. It doesn't take much time. All right. Which of these medications are examples of first line for pediatric blood pressure treatment that is not emergent? Spironolactone, enalapril, metoprolol, amlodipine, B and D. Good. Okay, ton of references. Shout out to my wonderful partners at the Adolescent clinics. And this is Fleming and Patrick Henry. If you have students that go there, tell them to come down and see us if you're worried about them. We'll check their blood pressure for you. And their lipids. And just, I didn't say this, but remember that our lipid screening is very good, but if you're gonna, before you're gonna do treatment on hyperlipidemia for a pediatric patient, please bring them in for like a fasting lipid so that you really know from a venous draw what they have going on. Because again, if they've just had the Frappuccino, their triglycerides will probably be high. So I don't want you to overtreat them. Questions?
I just had a question about the uric acid lab.
Yeah.
So just so I understand, is the point of that to, if it's like you get the result and if it's high, it's just supporting the diagnosis of primary hypertension, or are you doing anything else?
Think twice about whether you need to do all of that secondary workup. If that's high, it probably means they've already had a little endothelial dysfunction. This is in a healthy kid has no other past medical history, and the rest of their exam is totally normal. It can really kind of reassure you. It doesn't necessarily mean you're not going to get a CMP and stuff too, but just think about it. I think it's an interesting correlation, and we're learning more and more about how fructose metabolism is disturbing uric acid levels and then disturbing the nitric oxide Teflon coating of the endothelial lining in the 66,000 miles of endothelium that we all end up growing into.
Okay. Thank you.
So I want to preface this by saying that none of the cardiologists have any formal training in lipid management, but we get a lot of referrals for it. Can you speak to the use of fiber as a therapeutic adjunct and what the goals are for that? And then isolated hypertriglyceridemia, What are your goals? First of all, from an adult perspective, what is the data for isolated triglyceride elevations in terms of cardiovascular risk? How that applies to adolescents, and what cutoff numbers do you recommend starting statin therapy? Because we get a lot of isolated hypertriglyceridemia.
Yeah, so great question. So the questions are all about hypertriglyceridemia and and fiber use. So certainly fibrates. So the medical, like Gemfibrozil and stuff like that, has data that is very scant in less than 18-year-olds. However, if it's a young person who has had recurrent pancreatitis due to elevated triglycerides alone, that would certainly be someone that you might want to try it in. Levels are a little bit tricky, so triglycerides certainly have a high correlation with cardiovascular events in the adolescent and adult population, particularly if they're over about 250. We get very nervous in that. If you have alterations in both the triglycerides and the LDL-C, then you may want to think about going to statin kind of stuff a little bit earlier just to get that LDL down. It might be helpful if the triglycerides are so high that all you keep getting back is a calculated LDL on the venous measurement, to actually, in those folks, do the apolipoprotein B, because that's a cheap test. It'll actually correlate better with the number of LDL particles, and so that might help you to kind of know if you should just go right for the statin. Other forms of fiber other than fibrates do have some role in lowering triglycerides. Probably the biggest bang for the buck would be getting them off sugar, off a high fructose corn syrup, and fiber would be, in some form, even if it's, benefiber, even if, or increasing good dietary fiber in their, in their diet. But you're absolutely right that those patients who have isolated hypertriglyceridemia like Kevin, his LDL actually came down with management. His triglycerides always kind of stayed up. And you have to be thinking about diabetes in those folks too, because typically they're running higher sugars than what we know. And so those are certainly people that we need to think about hemoglobin A1C to see if they're running a little higher over time. But yeah, you'd have a lower threshold because that's a double whammy. If your LDL is high and your triglycerides are high, those are kind of double whammies for endothelial deposition of atherosclerotic plaque and problems, coming down the road. Did I answer your questions?
Well, the fiber typically will use more in LDL elevations and then omega-3s for triglyceride
yeah.
elevations. But let's say their LDL is completely normal, triglycerides are 300.
Okay.
You've already got them on a omega-3. Is 250 your cutoff for a statin in that case? Is it 500? Is it 800?
The adult cardiologist would probably say at 250, like get them down because they're in for trouble. So starting a low dose statin is probably very reasonable if they've still got 250 and above triglycerides in that kind of a scenario, just because their long-term ramifications are so devastating potentially. They want us to be more aggressive in the pediatric world if we can. Go ahead.
So there's a lot of calls for this to not go to cardiology clinic, and end up with the general pediatricians managing it. And a lot of us are not being trained in this, or haven't been trained, and now are looking to try to train our residents and stuff in this. And so I appreciate you kind of bridging that, right? Because your adult experience, I think, is really helpful. As we look to start managing these kids, primarily I see them on lisinopril. If they're going to be on medications, do they typically respond to one agent? In the adult world, I know that it's multi-agent or going down the line. So as we think about what kids can stay with us, if we get to our second agent, should we be concerned more about this being a refractory case and getting further evaluation, or is that kind of run of the mill?
Well, if you've maximized one agent, and that's been controversial. So with hypertension management, we used to say maximize one agent before you added a second agent. I think in the pediatric population, if you have somebody that you've ruled out all the other secondary causes, you know that their kidneys are fine, there's not another, problem going on, you could think about a second-class agent in addition before necessarily referring. The beautiful thing about pediatrics is they're all likely going to become adults, and so you will likely be able to pass them off to someone in the not-too-distant future who is very comfortable with managing, 2 or 3 medications, for a problem. Most of by and large, most of the pediatric patients are going to respond to a single agent and even a modest dose when it comes to blood pressure. And, in terms of but you don't have to be worried about that either, because you can always dose the second agent lower. I think the biggest thing is to really just, get their blood pressure down. And I always tell these kids that this may not be something that you have to stay on for life, but these are the things you got to do. And like I said, you're usually, talking to a whole family when you're talking to that kid. And so if you will actually do these things, nobody likes to take medicines every day. That's a drag. And I don't want you to take medicines. I would prefer you had no medicines when you, come to see me when you're 50. That would be great. If you don't need them, that would be super. But if you don't do these lifestyle modifications, this is one of your, you're probably going to be on some meds.
This is not so much a question as a comment, but thanks, Austin. It was a great segue into what I was going to say anyway. This is a great talk, Jeri. I mean, I think it's a challenge where we see our pediatric population is now developing different illnesses that we weren't trained to take care of. A great example would be mental health. We've now learned that we can treat depression, we can treat anxiety, and we need to. The need to bring that into primary care, and I think that's huge. Steve's comment that, well, he didn't have formal training. Well, he's probably got a little better background from his core knowledge base and where he's kept up with pediatric cardiology. So our excuse of we haven't had formal training isn't necessarily a good referral reason to send him to Steve, and also to keep his head above water.
We'll see him. It's again, and the same thing with hypertension. My training is from my peds nephrology rotation.
So I think we need to think about it. It's too easy to refer in many respects. I think that's across the board when we look at the access to care. The access to care to cardiology is difficult because those guys are working their butt off. So it's just, thanks for coming out. I'm going to advertise this for those that missed it.
We got some in the chat.
Okay, go ahead.
Dr. Kreider said, do you have any dietary guidelines, smart phrases, and epic we can steal to put in patient handouts? Plagiarism is the best compliment.
No plagiarism, Amy, it's research.
Yes, Dr. Kreider, I do, and I will share them with everybody.
Yes, thank you. And then we had Dr. Ferrer. I don't think she is local. How often do you recommend screening for lipid? We have a lipid machine in office and start screening at 10 years old. When should we be repeating it if it is normal initially?
Okay, so the guidelines say 9 to 11 once, and then don't forget to recheck them before they leave into adulthood. So like 17, you should probably check again. If it's high, just check it again, in 6 months. Please don't forget them. Don't just check it, go, it's high. I talked to you about lifestyle modifications. Please don't not check. Maybe then you've ruled out some of the severe familial hyperlipidemia by that first check, but it doesn't mean that they're following your dietary recommendations.
And then just one more from Dr. Keys. Is there an association with the use of statins and type 2 diabetes?
Well, tricky. Okay, so chicken and the egg, okay? So you can find literature to support either end of the answer to that question. And, again, always look at your literature to see who sponsored it, because sometimes, you have perhaps a skewed view. So there is not a clear association that going on a statin gives you diabetes, okay? I will just leave it at that. But I will say that if you want to look for that literature to support either end of your argument, you will find studies that come with that conclusion. But I want you to think about it more as the wave of metabolic syndrome is so huge in this country. It is ridiculous. Before 1960, we had no chronic diseases requiring everyday medications. The first chronic medication that folks were put on was birth control pills, okay? That people were on for long periods of time. So if you think about great-grandparents, they died of like hardening of the arteries, or trauma. But they weren't on blood pressure medicines for, 30, 40 years. So there's something, in what our society has kind of done with, foods and processing and exercise and light and sleep and, stuff has changed. So, in the last 60 years. So, so it's hard to know how many of the diabetics, maybe were undertreated for hyperlipidemia, but they all kind of probably blend together. The diabetes, the hypertension, the hyperlipidemia, but I think for us as pediatricians, if we can at least find those folks who are at, severe risk going down the road, the stage 2 hypertensions, and find those familial hyperlipidemias that need to have aggressive lowering, that'll really kind of change the trajectory of health for our patients.
I was going to say, you touched on this earlier, that I think that making the argument to families that about these cardiac risk factors, including sleep apnea, obesity, diabetes, and these two, is when these adult studies are showing they're peaking after they've been living with the disease process for 20 plus years. So they're then having them in their 40s and 50s and 60s, depending. Since we're seeing these things so much earlier in adolescence, by the time they get to their 30s, they've been living with it for 20 years. So when we're making the arguments to them, it's the mileage, right? It's not the age.
Exactly.
Usually it's used the other way, but we're using it in kids, is getting on board with this now.
Yep.
If you don't make these changes now, that by the time you get to your 30s, which is a young adult age that sometimes they can see in the future, you could start having your first event could occur as young as your 30s, as opposed to your 50s and 60s when you don't see it. Because in adolescence, they don't see the big picture. A lot of times the parents don't see the big picture because they're coming in with the same health issues. But showing them, you didn't develop these problems to the parents until you were in your 30s and 40s, and now here's your concerns. Your child has these same problems at 15 or 13 or 11.
Yeah.
And you don't want to see this happen 20 years from now. So that's the arguments that we make in the clinic.
Yeah, great. That's a great way to put it.
For risk.
Perfect way to put it. So Dr. Hare was just saying it's the mileage and the length of time, so impressing that point to, our patients and to our families that they probably, if they've already got this problem, it hasn't just appeared overnight. This did not just happen last week. It's probably been creeping up for a while. So the time to take action is great.
I've had patients that even the family has said, I thought their blood pressure was high, but no doctor's ever talked about it or been worried. And then just commenting on it makes a difference to families. Even if it's
because most
not at a
adults
level
know.
you're quite gonna start doing a big investigation, but a 5-year-old with 120 over 80, everyone brushes off as normal because it's normal in the adult.
Yeah, no, that's a great point. So Virginia's just saying, Dr. Powell's just saying that, when the adult or when the parents in the room kind of say, oh, I thought that blood pressure was high, but nobody's ever said anything about it. It's a great opportunity for time to.
Whatever gets mad. This is not us. They're in the middle.
Thank you, Dr. Lantz. Don't forget to fill out your evaluation.